Sciatic neuropathy stands as one of the most significant neuropathies affecting the lower extremity, second only to peroneal neuropathy. The sciatic nerve formed from the spinal roots L4 to S3 travels from the pelvis through the gluteal region and down the leg, making it vulnerable to various injuries. Its unique anatomy with limited connective tissue support and anatomical variations increases susceptibility, especially in the peroneal division. This video explores a 6-year experience from a referral center, focusing on the electrodiagnostic features of sciatic neuropathy, its causes, and clinical implications. Electromyography, or EMG, is a powerful tool for detecting and localizing nerve damage, assessing the severity of neuropathy, and determining prognosis. Despite its utility, comprehensive electrodiagnostic analyses of sciatic neuropathy are rare in medical literature. This study bridges that gap by reviewing 6 years of EMG data, providing valuable insights into the patterns and severity of sciatic nerve injuries. EMG helps clinicians distinguish between different types of neuropathies and guides appropriate treatment strategies. Study reviewed the EMG database from 2017 to 2022, including 58 patients diagnosed with sciatic neuropathy. Patients were divided into adult and pediatric groups, with adults further categorized by etiology, injection trauma, non-injection trauma, and other causes. Pediatric cases were not subdivided due to their small number. The analysis excluded patients with plexopathy or pure lumbosacral radiculopathy, ensuring a focused look at sciatic neuropathy. Clinical and neurophysiologic data were meticulously collected for comprehensive evaluation. Among the 57 patients included, 9 were pediatric and 48 were adults. The pediatric group consisted of 6 boys and 3 girls, with an average age of 10.3 years. Adults had a mean age of 43 years with a higher proportion of men. Sciatic neuropathy was more often left-sided in both groups, and only one adult had bilateral involvement. These demographic details help contextualize the findings and highlight the broad age range affected by sciatic neuropathy. Most common cause of sciatic neuropathy in adults was injection-related trauma, accounting for 37.5% of cases. Non-injection traumas, such as direct injury, surgery, or bone fractures, were equally prevalent. In children, injection trauma, sciatic mass, and postoperative complications were noted. Other rare causes included tumors, vasculitis, and genetic syndromes. Understanding these etiologies is crucial for prevention and targeted management. Patients with sciatic neuropathy, often present with sensory and motor deficits in the sciatic nerve territory. Drop foot was observed in 66.7% of pediatric and 37.5% of adult patients. The duration between symptom onset and EMG varied widely, from less than a month to over 3 years. Some adults had comorbidities such as malignancy, diabetes, or rheumatic diseases, which could influence the presentation and progression of neuropathy. Electrodiagnostic EDX testing included nerve conduction studies (NCS) and needle EMG. NCS assessed both sensory and motor nerves using standardized electrodes and protocols. Key variables measured included compound muscle action potential (CMAP), sensory nerve action potential (SNAP), distal motor latency, and nerve conduction velocities. Needle EMG evaluated muscle activity at rest and during contraction, grading the severity of nerve injury based on established criteria. Nerve conduction studies revealed that total sciatic nerve involvement, where both tibial and peroneal nerves were not excitable, occurred in 10.3% of patients. Partial involvement was more common with varying patterns, predominant tibial, predominant peroneal, or similar involvement of both. These findings help differentiate the extent and type of nerve damage, which is essential for prognosis and treatment planning. Needle EMG grading system classified findings from grade 1 to grade 3 based on the severity of nerve injury. Grade 1 indicated mild changes, while grade 3 reflected severe neurogenic alterations and loss of muscle unit action potentials. In both injection and non-injection trauma groups, grade 2 findings were most common in the gastrocnemius medialis muscle. Higher grades were more frequently observed in peroneal division innervated muscles, such as the tibialis anterior and biceps femoris short head. Statistical analysis showed no significant differences in nerve conduction parameters or needle EMG finding between injection and non-injection trauma groups, except for lower sural snap amplitudes in non-injection trauma. This suggests that non-injection traumas may cause more severe sensory nerve damage. However, peroneal and tibial CMAP amplitudes tended to be higher in injection-related injuries, though not statistically significant in this sample. Anatomical variations of the sciatic nerve, such as its relationship with the piriformis muscle, can influence susceptibility to injury. Type B and C variants, where the nerve divides earlier or passes through the muscle, are more prone to damage during procedures like hip arthroscopy or intramuscular injections. Awareness of these variations is vital for clinicians to prevent iatrogenic injuries. Study highlights that peroneal division injuries are more common and severe, especially in the context of sciatic nerve variations. Needle EMG abnormalities are more frequently detected in muscles below the knee, particularly those innervated by the peroneal nerve. These insights are crucial for clinicians in diagnosing, localizing, and managing sciatic neuropathy effectively. Pediatric cases of sciatic neuropathy are less common and often linked to injection trauma, tumors, or postoperative complications. The study adds valuable data on pediatric patients, emphasizing the need for careful assessment and tailored management in this age group. Early diagnosis and intervention can significantly impact outcomes for young patients. While the study provides comprehensive insights, some limitations exist. Detailed causative drug information was missing for injection neuropathy cases, and the sample size limited statistical power for some comparisons. Future prospective studies should include more detailed data collection and larger pediatric cohorts to further clarify the nuances of sciatic neuropathy. Summary: this 6-year review underscores the importance of electrodiagnostic studies in understanding sciatic neuropathy. Injection trauma remains the leading cause in adults, with perineal division injuries being particularly prevalent. Non-injection traumas may result in more severe sensory deficits. Recognizing anatomical variations, employing thorough electrodiagnostic testing, and considering patient demographics are key to effective diagnosis and management. Continued research and awareness will help improve outcomes for patients with sciatic neuropathy.